So we are going to talk of this term long COVID. As you know that most people with COVID up to 85% will experience only mild symptoms and moderate illness. Now 15% almost cases will progress to severe disease and about 5% will become critically ill. Typically, the recovery of COVID will be between 2 to 6 weeks, depending on how mild the disease has been and how severe. So severe cases may take up to 6 weeks for recovery. Now, all these patients of COVID, the symptoms may linger or recur for weeks or months following initial recovery, even in milder cases. So this data has come that even 20% patients who were previously in young age group with a good health previously have reported prolonged symptoms after COVID has subsided. The common risk factors for persistence of symptoms which were found were hypertension, diabetes, chronic medical conditions, obesity, and mental health conditions. The symptoms that usually patients come with, the most common symptom is fatigue, which is seen in almost 70 to 80% patients, cough, congestion, and shortness of breath, which we'll be talking about, loss of taste and smell, headaches, diarrhea, nausea, chest and abdominal pain, and confusion. And the post-COVID respiratory problems, patients are often coming with prolonged cough, congestion, and shortness of breath. The most common problems that we'll be talking about is a fibrotic lung, bronchiectasis, pulmonary vascular disease, and recurrent chest infections. Now, these evidences are coming from acute manifestations of COVID, and the data has also been extrapolated from the previous SARS 2003 outbreak, which was again a coronavirus disease, and the data of ARDS patients. What are the post-COVID respiratory complications? The most serious and life-limiting complications would be pulmonary fibrosis and pulmonary vascular disease. And patients at highest risk of these complications are, you have background risk factors like old age, male gender, smoking, and chronic alcoholism. All patients who have been managed for moderate to severe disease in ICUs and HDUs, patients who have required high FiO2s, CPAP therapy or NIV, patients who had significant comorbidities which puts them at risk of early respiratory decompensation, any patient who's been discharged and the discharging team or the team managing the patient had significant concerns about, and patient who has been discharged on oxygen therapy at home. So all these patients are definitely at risk of prolonged respiratory complications. Now, first we will be talking about post-COVID pulmonary fibrosis. Now, fibrosis is not something which is unusual. Any infective process in any part of the body will be healing by scarring, and that is exactly what fibrosis is. But now, as the burden of pandemic was large, a lot of patients with COVID, acute COVID who were recovering, they are coming back with severe residual lung fibrosis and oxygen dependence. Now, what factors could be responsible? There are cellular changes like genomic instability, mitochondrial dysfunction, epigenetic modification. All these things reduce the cell's ability to respond effectively to virus. This triggers off a pathway of inflammation and autoregulation, and this dysregulated autoregulation will lead to repair and fibrosis. Now, there are theories, the virus-induced factors will be increased fibrogenic cytokines like TGF-beta, and also it is known to react with the ACE2 inhibitors. So there is downregulation of ACE2, which leads to increased angiotensin 2 levels, and both these factors are basically pro-fibrogenic factors. They will lead to myofibroblastic activation and ECM accumulation, which promote fibrosis. The other thing which we should not forget are iatrogenic factors in promoting lung fibrosis. So we should not try to super oxygenate our patients during management. And also there's an element of ventilator associated lung injury which may speedily promote lung fibrosis. Now, this is a typical CT scan of a patient. Two patients have put recovering from COVID pneumonia. One is the first patient. It shows typical case which has multiple bilateral peripheral GGOs. And the morphological pattern of lung disease in COVID, as you can see on the left side of both the patient, the panel on the left side, we have ground glass opacification, consolidation, foci of edema, organizing pneumonia, and DAD. These radiological changes do not resolve in some patients completely, and the inflammation matures to form residual pulmonary fibrosis. Now, patient 1, you can see this progression from the GGO pattern to the fibrotic pattern seen on the right side. It has happened over a span of 3 months. Now, in the other patient, it has progressed even in 3 weeks' time, almost 2 weeks' time, that the patient has developed almost a UIP pattern. So the speed of progression to fibrosis, it cannot be decided. It is not. It may depend on many patient-related and environmental factors as well. And the fibrosis ranges from organizing pneumonia pattern to NSIP pattern to UIP pattern, as I've shown in the panels. and it may develop over weeks to months. The second thing we are concerned about is pulmonary vasculopathy in post-COVID lungs. So we have, as sir has already pointed out, Dr. Sudeep, that the same thing happens in pulmonary vasculature. You have microthrombosis and higher degrees of angiogenesis. And as we can see, there's a great deal of in dual energy CT scan, which is basically showing the iodine uptake. We can see there is a lot of mosaic attenuation, and the vasculature is definitely involved in terms of dilated vessels and perfusion abnormalities. So long term, the vascular injury, abnormal vasoregulation, and resulting chronic pulmonary thromboemboli will lead to persistent hypoxia in the patient, and they further contribute to respiratory discomfort. Now coming to evaluation, these two problems of fibrosis and vasculopathy cause persistent respiratory issues and significant morbidity. Now, what we have seen is the data which has come, which has shown that majority of patients infected with COVID-19 viruses are discharged with persistent radiological changes in almost up to 80% patients. But by 3 months time or 12 weeks time, approximately 2/3 patients have come back with normal or full X-ray resolution. A follow-up study of COVID-19 survivors at 6 weeks showed that 40% patients were reporting dyspnea at 6 weeks, 30% had DLCO reduction, which is a parameter in PFT. More than 80% patients had residual CT abnormalities. Evidence of interstitial thickening was seen as 30%. But when you actually follow these patients up at 12 weeks, the CT abnormalities dropped by almost 60%, and patients' scans as well as pulmonary function tests showed marked improvement. So reassuringly, these authors have submitted that progressive pulmonary fibrosis was not seen in any of their patients. Now, what is the natural history of post-COVID fibrosis like? It looks like, with the current available evidence, that most common pattern is patients will improve. After 3 months, the patients are definitely improving. Some patients may have a static disease, which is less common, and the least common, which everybody is talking about, is do we have a progressive fibrosis? So the data till now is that this is the least common group. It is a very rare complication, and I'm also yet to see many patients of this. Our patients are also improving with time. Now the optimal management, it remains unclear because, as you know, the management is evolving for COVID and post-COVID care as well. But definitely an integrated multidisciplinary approach is needed, where you have doctors as well as physiotherapists and psychotherapists. Now, investigations, first line would be a chest X-ray and serial SpO2 measurements during follow-up visits at 6, 12, and 24 weeks. There is poor correlation between symptoms and objective measures because patients often come with non-specific symptoms like fatigue, exercise intolerance, and poor concentration. So first, chest X-ray at 12 weeks is definitely helpful, and it may lead to early referral to specialized respiratory clinics for further workup. We may go for earlier chest X-rays in patients who have persistent severe disease or new symptoms or even unexplained clinical deterioration. The next line of investigation would be an HRCT scan or a CTPA, depending on what we are suspecting. We are also routinely doing pulmonary function tests. So 50 to 80% patients of COVID will have DLCO impairment at the time of discharge. Now, DLCO is a very important parameter because it is lower in severe disease already. That is something we already expect. But it is more sensitive to disease severity than the lung function parameters like FVC and TLC. And there is a parameter known as TLCO by VA. If it is found to be significantly lower, then you may actually suspect an additional or maybe a primary pulmonary vasculopathy over and above fibrosis angle. So pulmonary patients who are having vasculopathy eventually would need CTPA and echocardiography to find out chronic thromboembolism related complications. And this is a flowchart that we are following. Patients who are getting discharged, they are evaluated in person or telephonically at 4 to 6 weeks, and at 12 weeks we are doing the radiology and PFTs. And again, those patients who are having persistent issues, they will be going for high resolution CT scan and CTPA if we are needing. And depending if we are suspecting pulmonary hypertension, then again echocardiography. And then patients who are left with some sort of fibrosis are being managed in the ILD clinics. Now, are there any drugs which can help? So, as we know that steroids are part of the standard care now for acute COVID, what percentage of patients should go home with steroids? So, steroids should be continued at discharge when the CT scan continues to show significant GGOs or organizing pneumonia. So, it is important to pattern read the CT scan and not give steroids for all the patients. So organizing pneumonia and GGOs are the one which are going to respond, and the patient definitely he should be hypoxic. We are not using large doses of oral steroids because initially patient has been managed with such higher doses during acute COVID, and we are giving modest doses of 0.5 milligrams per kg body weight per day. And we should avoid these because, as we know, steroids have side effects. So hyperglycemia, proximal myopathy, which the patient is already having, and it promotes a lot of infections. I'll be talking about that in very brief. And antifibrotics. So I put a query on this. Antifibrotics, they are indicated in very, very, very few patients who have post-COVID progressive fibrosis. And again, I'm saying that you have to document the progression before even thinking of giving antifibrotics. Why I'm saying this is that any of the antifibrotics which are available, like pirfenidone and nintedanib, they take at least 1 to 3 months to even demonstrate an effect. So starting them in acute phase and not documenting progression, that wouldn't be a wise thing to do. And again, if you have been fortunate to document some sort of fibrosis progression, then you can use it in combination with steroids to counter both the limbs of a fibrotic pathway. And lastly, I just want to say one thing very categorically here, that post-COVID lung and infections, we are dealing with this problem a lot in last 3 months, because now we're getting post-COVID patients to manage. And patients are coming back almost within 3 months of their discharge. And what infections we have seen so far are hospital-acquired infections due to multi-drug resistant organisms like Acinetobacter, Klebsiella, and Pseudomonas. We are getting invasive pulmonary fungal infections. Aspergillosis is coming, like we're getting a lot of patients of that. Scedosporium, Candida auris. We have also documented a couple of cases of pneumocystis jirovecii, and one patient is still on ventilator with CMV pneumonitis. And patients are coming with reactivation of pulmonary tuberculosis who've had COVID in last 3 months. So this is something I want to point out, that use of steroids should be very, very guarded. This is all I have to say. Thank you.